Recording in progress.
Good afternoon, everybody, and welcome to our webinar, Cracking the Patient Code, Optimizing Blood Pressure Control. My name is Agnieszka Kapłon-Cieślicka from the Medical University of Warsaw, Poland, and it is a great pleasure for me to host this webinar together with Professor Anastas Dzudzi from Cameroon, who is the President-elect of Pan-African Society of Cardiology. Welcome, Professor Dzudzi.
Yeah, thank you, Professor Ignaska. It's a pleasure. It's a great pleasure for me. Thanks.
So we would like to welcome you all today, and this webinar is organized into a few parts. We will start with a short introduction, then Professor Dzudzi will talk us through treatment initiation for hypertension. Then I will talk a little bit about treatment intensification, and this will be followed by a Q&A session. So if you have any questions or any comments that you would like to add to the discussion, please feel free to type them into the Q&A window at the bottom of the screen. And during the Q&A session, we will do our best to address as many questions as possible. And then at the end of our webinar, Professor Dzudzi will conclude the webinar. So let us start, and let me just share my presentation with you. So I hope you can all see the presentation, and you can see that the introduction is entitled "The First Weeks Decide the Next 10 Years." And this is, of course, very true because we know that we treat hypertension now to avoid its complications in the next 10, 20, or 30 years. And of course, those complications affect the heart, the brain, the kidney, and eyes. And me, as a cardiologist, I most often treat cardiac complications of hypertension. And here on the left, you can see healthy, normal hearts. And to your right, you can see two different patients. The first patient is a patient with left ventricular hypertrophy due to hypertension, with heart failure, with preserved ejection fraction, and with severely enlarged left atrium, so at a high risk for atrial fibrillation. The patient here at the bottom is a very different patient, but these again are complications of hypertension, untreated hypertension. You can see heart failure with reduced ejection fraction due to myocardial infarction. And I think some of you have also spotted this area here. This is a gigantic aortic aneurysm, so another important and very dangerous complication of hypertension. But of course, we have other complications, just to mention stroke, cognitive impairment, and chronic kidney disease. And I think our main problem is when we diagnose our patients with hypertension is that we tend to think of those complications as something that will probably happen or not happen in the very distant future. So we tend to think that if the patient is just newly diagnosed with hypertension, then those complications do not affect him. However, let's take a look. Who are we really treating? Who are our patients with hypertension? If we take a look at data from the snapshot study, this was an observational study of patients with either newly diagnosed hypertension or hypertension that was already treated. And you can see an average patient here. So most of our hypertensive patients are in their 50s, 60s, or 70s. 43% of those patients in the snapshot study were male. So 57% were women, possibly because women live longer. So you could actually, we should probably have a woman sitting here instead of a man. And you can see that majority was overweight or obese. So there was a great potential for metabolic syndrome in those patients. 17% were smoking, and you can see their average blood pressure and LDL cholesterol here on the slide as well. So now let's imagine that such an average patient, a 66-year-old patient, similar to an average patient from the snapshot registry, a 66-year-old patient with systolic blood pressure of 139 and LDL cholesterol of 120 milligrams per deciliter comes to you. And this is a patient who's been recently diagnosed with a hypertension. And now, what do you think his or her cardiovascular risk is? And now I would like you to vote. Please vote if you choose answer A, so that the patient's risk is high or very high. Answer B if you think that it's moderate, or you can also check answer C if you think that there is not enough data to assess the patient's risk because, well, there is no non-HDL cholesterol. We don't know whether the patient is male or female, smoker or non-smoker, and we do not know the region where the patient comes from. So whether it's a low risk, moderate risk, high risk, or a very high risk region. So please choose your answer. So a newly diagnosed patient with hypertension, 66 years old, and this is his or her LDL cholesterol. Okay, and you can all see the answers, and I can see that most of you chose answer C. So basically you are saying what the guidelines are saying. You are saying that we should always assess our patients with SCORE2 or SCORE2-OP risk chart. But please let me try to convince you, and maybe you can, as your homework today during the afternoon, you can check risk 2, SCORE2 risk chart and SCORE2-OP risk chart, and you can see that actually if you have a patient who is 66 years old, who is in his 60s and has hypertension, he or she will always be at high or very high risk, especially if their LDL cholesterol is in that range. And it doesn't matter whether it's a male or female, whether it's a smoker or non-smoker, and where the patient comes from. So most of our patients, the majority of our patients, hypertensive patients, are at high or very high cardiovascular risk, unless they are very young and with no other cardiovascular risk factors. And you can see that also from the data in the snapshot registry. In the snapshot study, you can see that only 1% of those hypertensive patients were at low to moderate risk, and 99% were at high or very high cardiovascular risk. In fact, 86% of those hypertensive patients in snapshot registry were at very high cardiovascular risk based on SCORE2 or SCORE2-OP. But do we actually realize that? You can see physician's assessment here, and you can see that most of the patients were assessed as being at low to moderate cardiovascular risk, 44%, and only 23% were assessed as being at very high cardiovascular risk. So you can see that we have a tendency to underestimate cardiovascular risk in over 70% of our hypertensive patients. But there is another problem, and we have to remember that our hypertensive patients quite often have many comorbidities. And you can see that in the snapshot registry, 1/3 of all hypertensive patients had type 2 diabetes. And of course, we know that in patients with documented atherosclerosis, but also with diabetes, chronic kidney disease, familial hypercholesterolemia, or just markedly elevated single risk factor, for example, markedly elevated blood pressure or LDL cholesterol, those patients are already at high or very high risk, and there is no need to calculate SCORE2 or SCORE2 OP in those patients, because those diseases themselves put those patients at high or very high cardiovascular risk. So if we think of the journey of our hypertensive patients, I think if we diagnose our patient with hypertension, we usually tend to assume that our patient is somewhere in this green zone at the start of their hypertensive journey. Meanwhile, most of our patients are already somewhere down the road because their cardiovascular risk is already high or very high, and many of them already have some level of left ventricular hypertrophy. Many of them might have albuminuria, which indicates chronic kidney disease, even if their eGFR is normal. So basically, this means that they are already on the slippery slope and they are at the fast lane to dangerous complications of hypertension. And these dangerous complications of hypertension are indeed dangerous because they are the leading cause of death in ESC countries. And in fact, high blood pressure is #1 risk factor for global disease burden. And we could say, why is that? Hypertension is so easy to treat. However, you can see that of all hypertensive patients, less than half are aware of the condition, less than 1/3 are treated, and less than 10% are controlled. So this means that we actually have a delay every step of the way. So to conclude, please remember that the patients that we have just diagnosed with hypertension, these are usually already patients who are at high or very high cardiovascular risk. They are already down the road, so this is not the beginning. They already are at high risk of developing complications, cardiovascular complications, cardiovascular events in the next 10 years. And this means that there is no more time to waste, and we should really make an effort not to make any more delays in treatment initiation and also in treatment intensification. So now let's hear about treatment initiation. Professor Dzudzi, the floor is yours.
Yeah, thank you very much, Professor Agnieszka, for that brilliant talk and for giving me the floor. So my own talk will focus on choosing the right dual single combination. Why does the first step matters? And I have these are my conflict of interest. So more specifically, we are going to discuss, let's say, 3 major points. The first thing is to say why dual combinations are now first line. Which dual single pill combination should we choose? And does the answer differ in Black African patients? And then we will give the key take-home messages. If we look at the evidence, whether we look at the ESC 2023 guidelines or the ESC 2024 or the ISH or the WHO, whatever guidelines we look at, then the key message is always the same, is that single pill combination should be used at the early stage of the initiation of the treatment of hypertension in our patients. And this has consistently been sent out as the key message for all the guidelines. Why this? Because when we use a combination of medications at low dosage, then we have better tolerance, we have better efficacy. And then when it is in a single pill, then we also have improved adherence. And it has been also proven that in terms of cardiovascular outcomes, we have a benefit. This slide actually presents the two different approaches. whether we look at it from the step care approach, or we look at it from the starting with the single pill combination. Now, if we compare both, what we learn from this American Heart Association scientific statement is that uh, point number one is that starting with a single pill combination always give a better efficacy in terms of blood pressure reduction and also in terms of cardiovascular risk reduction. So that's point number one. And number two is that this benefit is not just addictive. This benefit is actually cumulative. So patients who will be started on single pill combination at the early phase will actually benefit much more, even in the escalation therapy later, when you move to triple combination, and later when you move to quadruple therapy. And we have some evidence about this. We have the Veronica trial, which has been published and which demonstrated that if you start with triple combination low dose medication, then you do better than actually doing a step care approach, which was the standard approach at that time. The good message from Africa is that African doctors are much more prescribing dual combination, as you can see here from the snapshot study data from Cameroon and Mali shows that single pill combination is prescribed in a minimum of 60% of patients who come for hypertension. But unfortunately, we are not reaching the targets. As you can see, the blood pressure control in these two countries is still far below the expectations, and much more clinicians are actually underestimating the blood pressure control. If we agree that single pill combination must be the first step, must be prescribed as early as possible, then which combination should we actually choose for which patient? Let's look at the Asian patients. The TOP-SYN trials actually compare three Moderns SPC in nearly 2,000 Indians: perindopril plus indapamide, indapamide plus amlodipine, and then amlodipine plus indapamide. So these three modern therapy were compared in a randomized trial, and you can see in terms of results that all the three combinations were effective in reducing the blood pressure. And in terms of controlling the blood pressure, 70% of patients achieved the target of less than 140/90 at the 1 month. And if you look at it from the reaching the stricter target of less than 130/80, then up to 40% of these patients achieve blood pressure control, meaning that the three combinations are really effective in reducing and controlling, reducing blood pressure and controlling hypertension. The question could be whether it is also well tolerated, and this study also showed that less than 3% of participants withdraw from the study due to adverse events. So the three combinations are also very well tolerated in Asian patients. As a clinician, the clinical decision could be, yes, how do we choose these combinations? I will advise looking at the profile of the patient. If you look at the profile of your patient and the dominant profile is like, for example, metabolic syndrome or type 2 diabetes mellitus, or salt sensitive or CKD tendency, then the choice is actually going to be a combination of renin-angiotensin-aldosterone system blockers plus indapamide, and evidence to support this come from advanced trial. Whereas if your patient has high risk or has endothelial or vascular disease or elevated blood pressure variability or a stroke risk, then the combination of amlodipine and RAS blocker is the choice. and evidence comes from ASCO-BPLA trial. Now, if your patient was a Black African, how would you choose? You can look at it from different angles, from the pathophysiology, from the trials, systematic review, and from the guidelines. In terms of pathophysiology, it is well known that hypertension in Black African tend to be low renin, salt sensitive, and volume expanded phenotype. And this is probably the reason why CCB and diuretic outperform RAS blockers as primary agents in this population. The landmark trial in this to really support this is the Creole trial, which compared in free pills amlodipine plus hydrochlorothiazide versus perindopril plus hydrochlorothiazide and hydrochlorothiazide plus perindopril. And this actually shows that amlodipine should be the backbone of the treatment of hypertension in the Black population. And this was later confirmed in systematic review. And that's the reason why when we look at the regional guidelines like the Pan-African Society of Cardiology guidelines or the ISH, or even if you look at the international guidelines, then the recommendation is really to say calcium channel blockers must be the backbone of treatment in these patients and associated with thiazide diuretics, which doesn't mean that other combinations do not work. It simply just means that amlodipine should be the backbone of treatment. So let me now conclude my talk with 3 key messages. Point number 1 is really to say, let's start with dual single pill combination. And we have really noted that all the guidelines are actually converting or have been converting to give this simple message. So monotherapy should rather be an exception. And the second message to say match the SPC to the dominant phenotype of your patient. If the patient is metabolic risk, diabetes, or salt sensitivity, or CKD tendency, then you rather choose RAS blockers plus indapamide. But if the patient is high risk or has a vascular disease, you better choose calcium channel blocker plus RAS blocker. And the third message is to say, if your patient is a Black African, then CCB combinations deserve special consideration, as all the guidelines now convert to really give this simple message that in Black Africans, CCB must be the base of the therapy. So thank you very much for listening, and I will stay available for questions and discussions. Thank you.
Thank you, Professor Dzudzi. So now let's switch to intensification. So you talked us through treatment initiation, and now we already have a patient who already has, sorry for that, who's already been diagnosed with hypertension, and I would like to discuss this based on a case of a patient who's actually quite similar to the average patient from the snapshot study that we've discussed before. So a 66-year-old patient with hypertension treated for 3 years, and his mean blood pressure during home blood pressure monitoring is 139/82. You can see that the patient is overweight, but he's a non-smoker. He has no other known diseases, no cardiovascular symptoms. In fact, he actually feels very well. He feels healthy. On ECG, there is sinus rhythm, but on echo, we can already see some mild left ventricular hypertrophy. And you can see his blood tests here on the slide as well. The patient is treated with ramipril 5 milligrams once daily and amlodipine 5 milligrams once daily. So now my question to you is this patient's blood pressure controlled? And we will not take a vote because I'm sure you would all answer that, of course, his blood pressure is not controlled, because our blood pressure target, according to the ESC guidelines, our blood pressure target in the majority of hypertensive patients is 120 to 129 of systolic blood pressure and 70 to 79 millimeters of mercury for diastolic blood pressure. Now, this blood pressure target, this is not an expert consensus. This is actually, it's been derived from an analysis of randomized controlled trials. And this analysis has shown that more intensive control of blood pressure reduces cardiovascular events such as stroke, heart failure, myocardial infarction, and cardiovascular death. And you can see that average blood pressure in this more intensive arm control was, as recommended now by the guidelines, below 130/80. So it was 120 something over 70 something. And there is one more very important message here on this slide. Please take a look that this reduction in cardiovascular events with more intensive blood pressure control was compared due to less intensive blood pressure control. And in this less intensive arm, blood pressure was actually not that bad, we could say, because it was below 140/90. So these were not patients who were very poorly controlled with blood pressures of 160. No, these were people who had their blood pressure, average blood pressure of 138/81, and still they had higher risk of stroke, heart failure, myocardial infarction, and cardiovascular death than patients who had more intensive blood pressure control. So we already see that this patient needs antihypertensive treatment intensification. And now my next question to you is, how would you intensify? And this time I would like to ask you to vote. So please choose one of the 4 answers. First of all, it's obvious for us that, especially after Professor Dzudzi talk, that we will aim for an SPC. But now what would you choose? Would you simply increase the dose of ramipril and amlodipine from the low dose to the high dose? Or maybe you would switch ramipril to valsartan and use it together with amlodipine at high doses? Or maybe you would switch ramipril to perindopril and use it in combination with amlodipine again at high doses. Or maybe you would switch ramipril to perindopril, but you would combine it with indapamide and amlodipine, so a triple combination in low doses. So I'm very curious what answers you will choose. So please vote. And here we have our answers. And as you can see, the majority, so 41%, chose the triple combination of perindopril, indapamide, and amlodipine in low doses. This is actually what I would choose as well, and what has been done in this patient. So spoiler alert. But let's discuss all the other answers. Many of you have also chosen answer A, so to stick with ramipril and amlodipine. But let's see if that's actually a good idea. Of course, as it was already discussed, we know that in patients with high or very high cardiovascular risk, ACE inhibitors are superior to ARBs in terms of cardiovascular protection. And this is probably due to, for example, bradykinin effect of ACE inhibitors. So we know that we should not simply change from an ACE inhibitor to ARB, especially in a patient at high cardiovascular risk. And we know that our patient, the patient that we discuss now, is at high or even very high cardiovascular risk. But there is also one other very important matter, and this is trough to peak ratio, so T2P ratio, which actually tells us how long the drug is effective for. And you can see that TP ratio of perindopril is close to 100%, which means that this drug actually acts for 24 hours. So we have our patient protected for the whole day and the whole night. And if you compare it to ramipril, you can see that TP ratio of ramipril is only approximately around 50–60%. So this is why actually ramipril for blood pressure control should be given twice daily. But naturally, we want to reduce pill burden. We want to use a drug that will offer protection for the whole 24 hours. And of course, reducing pill burden means also putting this into an SPC. So you can see that perindopril should be preferred mode of action here, not only because if it's pleiotropic effects like bradykinin effect, but also because it's a very nice long-acting, very effective drug. Of course, as Professor Zuzzi also showed us, single pill combinations are now the gold standard for antihypertensive treatment because they increase adherence, improve blood pressure control, and therefore reduce cardiovascular morbidity and mortality. And of course, as Professor Anastas showed us, we start antihypertensive treatment with a low dose double combination. Then preferably after 1 month, we want to see whether or not our patient achieved blood pressure control. And in case he didn't, and our patient didn't achieve blood pressure control, we should intensify. And now, as you can see, the ESC guidelines recommend early intensification through adding a third drug, so low-dose triple combination therapy, rather than simply increasing the dose of the 2 drugs. Why is it so? Because you can see that adding another drug is much more effective in terms of blood pressure reduction than simply increasing the dose, doubling the dose of the previously taken drug. You can see that if we just double the dose of a single drug, what we achieve is 2 millimeters of mercury additional reduction. Meanwhile, if you add another drug, you can see this additive, or as Professor Zuzzi said, cumulative effect on blood pressure reduction. And this is, of course, extremely important because the bigger the reduction, the lower the risk of cardiovascular events. And we remember that our patient is already on the fast lane towards all of those dangerous complications of hypertension, because this is already a patient at high or even very high cardiovascular risk, already with left ventricular hypertrophy. So this is his trajectory. And can we actually reverse this trajectory? Can we change it? We actually can, and using a triple SPC of perindopril, indapamide, and amlodipine is a very good way to do that, because you can see that this SPC is extremely effective at reducing left ventricular mass index. So we have a drug that can actually reverse left ventricular hypertrophy. And of course, using these 3 very potent drugs in an SPC is much more efficient compared to using them separately in 2 or 3 pills, because it increases adherence and it leads to a reduction in deaths and cardiovascular events. And this is why the triple SPC of perindopril, amlodipine, and indapamide is now one of the essential medicines by the World Health Organization. So finally, our patient has been given this triple SPC of perindopril, indapamide, and amlodipine. And of course, we will schedule another visit in a month to see whether or not he's already achieved his blood pressure targets. But my last question to you is, should we do anything else, or are we just happy with the antihypertensive treatment that we offered him? Well, of course, we are not happy, because this patient has many more risk factors to address. So first of all, as a high risk or very high risk patient, he cannot he cannot walk the streets with an LDL cholesterol of 120 milligrams per deciliter. So definitely he needs a high intensity statin treatment. And of course, we should also address the problem of him being overweight. So we have already therapies for that as well to help our patients. So what I think is extremely important to remember that we should address all risk factors and that there is no time for delay in treatment intensification. We cannot postpone it for later. We should aim at blood pressure targets and we should use triple SPCs to achieve that control. Thank you for your attention. And now let's go to the Q&A session. We hope we have many questions from you, and we can already see some questions here. So let me see. Okay, so first question that we can see here is, why do we observe that most patients with high blood pressure also have diabetes? Well, I'm not sure this is true. For example, the snapshot registry showed 1/3 of hypertensive patients with diabetes. And of course, this will all differ depending on the population that we will assess. To be honest, it would be best to diagnose patients with hypertension before they are so ill enough to develop diabetes. So usually hypertension does start a little earlier than diabetes does, but of course it varies. It depends on the patient and his metabolic risk. Another question, maybe Professor Dzudzi can answer that. What can we do with regards to how we monitor blood pressure in order to more accurately determine control to avoid overestimation of control? Well, I understand that this question simply means, how do you monitor blood pressure in your everyday practice?
Yeah, I think that's a very good question, which reflects our clinical practice. I use, of course, office blood pressure monitoring. That's really what has been used in in the majority of clinical trials, and is still quite effective. But if we have access to ambulatory blood pressure monitoring, then that's really it is the standard to know whether our patient is controlled or not. And much more, I will also encourage home blood pressure monitoring, because we always have to really get an idea of what is happening out of the office, because some of our patients might be having mask hypertension, and we need to detect this and treat the patients optimally so as to reduce the chances of cardiovascular disease. As well as, of course, white coat hypertension should always be ruled out when we think that the patient is compliant with treatment and that we don't achieve the target. So having figures of the blood pressure out of the office is very important. And this has also been correlated with target organ damage.
Exactly, I completely agree. I think it's even more important than office blood pressure measurements. And it's actually what we can use not only to control blood pressure in patients who are already diagnosed with hypertension, but we can also use it to detect hypertension. But just please then remember that then the cutoff for diagnosis is 5 millimeters of mercury lower than for office blood pressure measurements. So it's 135/85 millimeters of mercury. But it's a very good method. And just as Professor Dzudzi said, it is actually, it correlates better. Home blood pressure monitoring correlates better with end organ damage than office measurements, which sometimes are a little random, we could say. We have some more questions. For example, the question in the decompensated heart failure patients, whether antihypertensive therapy, whether it should be given or not. Example, beta blockers prescribed or not. Well, let's start with the fact that decompensated heart failure can have many reasons and many phenotypes. So it all depends. We can have decompensated heart failure in a patient with heart failure and preserved ejection fraction due to very high blood pressure. So of course, this will be a patient who will need very intense antihypertensive treatment. But I think that maybe the question was more about heart failure with reduced ejection fraction. These patients, when they are decompensated, of course, they do not like high blood pressure as well. And it's very important to treat blood pressure and achieve blood pressure targets in every heart failure patient, because it's of course easier for the heart to pump against lower blood pressure. So that's why we give vasodilators actually in heart failure as well, because we want to have low blood pressure, so it's easier for the left ventricle to pump blood out, and then we have less congestion in the lungs. But of course, in many patients with HFrEF, we have the problem of low blood pressure, and we know that we are not afraid of low blood pressure in those patients. Of course, these are very different patients. They will receive ARNI if only available. And regarding beta blockers, of course, we will be more cautious with beta blockers in patients with HFrEF and decompensated heart failure. Sometimes we even need to reduce the dose, or sometimes even maybe to temporarily stop beta blockers. But basically, as soon as we are already able to introduce beta blockers in HFrEF, of course, we will do that. But of course, these are very, very different patients. I'm looking for some more questions here. How does a high TP ratio translate to the prevention of the morning surge in blood pressure? Specifically, do agents like perindopril or telmisartan offer superior protection against early morning cardiovascular events? Well, this is exactly why we choose antihypertensives with high T2P ratio. First of all, because it enables us to give those drugs once daily, and to reduce pill burden. And also, secondly, just as our participant noticed, this is something that helps to maintain the stable blood pressure throughout the whole 24 hours, and it can prevent a morning surge in blood pressure. I don't know, Professor Dzudzi, would you like to comment on that as well?
I don't really have an addition to that. I absolutely agree with you. That's the reason why we use those two medications. Sure.
Okay. Okay, there is another question. Do you still, maybe for Professor Dzudzi, do you still prescribe B therapy, so double therapy medication as first intention, even if the patient doesn't have any cardiovascular risk or comorbidities?
Yeah, I don't know exactly what was the idea behind the question, but I guess the question is to understand how to select therapy in people who have multimorbid condition. And as you rightly presented in the snapshot, most of our patients usually have multiple comorbidities. So I would say the first thing is really to evaluate the clinical profile of the patient and to really decide on the most dominant phenotype. And once the phenotype decided, if, for example, it's a patient with metabolic risk or diabetes, then we'll tend to favor RAS blockers plus diuretics, especially if there is a CKD tendency. While on the other side, if your patient is already presenting with cardiovascular disease, like complications, stroke, myocardial infarction, this patient is high risk, and therefore we should prescribe a combination of RAS blockers and amlodipine. Most of our patients usually have multiple comorbidities, several phenotypes, but it is always important to say, okay, the most dominant phenotype is this, and then that will give an orientation. And I want to end there by saying that these patients with multiple comorbidities and who at times are having target organ damage are not going to be controlled with a single dual combination. And as Professor Agnieszka rightly said, these kind of patients will benefit from a triple therapy and optimally starting with low dose and then escalating later to really achieve the target. Thank you.
Exactly, and I'm not sure again also that I understood the question correctly, but maybe I think that the question was that if we have a patient who is hypertensive but doesn't have any comorbidities or doesn't have very high risk, would we still prescribe a dual combination? Of course, we both would, just as Professor Anastas said. So basically, if you have hypertension, so if you have office blood pressure over higher than 140/90, or if you have average home blood pressure measurements higher than 135/85, this means you have hypertension. And if you have hypertension, the first step is using dual combination, and there is and this is it. We can use monotherapy if you have patients who have elevated blood pressure, so not yet hypertension, but already blood pressure higher than 130/80, and who are at high or very high cardiovascular risk. And these will be candidates for monotherapy, usually with an ACE inhibitor. But these are patients who are actually not yet diagnosed with hypertension. But once you have diagnosed hypertension, the first step is to use double SPC. Well, unless it's a very, very old and frail patient, then you can sometimes choose monotherapy. But basically, yes, the answer is yes. The first step is dual SPC. Another question, an interesting question, I think, drug of choice for diastolic high blood pressure. My answer is, well, basically, again, we use combination therapy, but if I see high diastolic blood pressure, it's quite often that the patient is volume overloaded, so a nice effect could be seen with indapamide, with a diuretic. What is your view here, Anastas?
Yeah, absolutely share the point. Of course, most of the time when you are targeting the systolic, you will also be effective on the diastolic. But if the diastolic tend to be much more elevated than the systolic, then think about the high volume and then diuretics, and especially indapamide will be more indicated in those patients.
We have a personal question here. I have been experiencing BP values of 145/87 myself. I'm 37 years old and BMI of 29 with a family history of hypertension. What should I do? Well, it depends on what you mean by experiencing, because of course, if you are in pain and you experience blood pressure rise, this is normal. But if by experiencing you mean that you regularly have those blood pressure values, well, if your average blood pressure is 145/87, you have hypertension, so you should start a dual SPC. And for your BMI of 29, of course, it is extremely important to have the right lifestyle, so lifestyle modification, with the right diet, with exercise, but this, of course, with the BMI above 27 and already cardiovascular complications, we know that drugs such as semaglutide are already indicated. So if you have possibility to use such a drug, it is indicated, not only to reduce weight, but actually to live longer, because we know that these are also cardioprotective drugs that reduce cardiovascular events. Okay, we have another interesting question here. Maybe I will direct it to Professor Anastas. If a patient, I'm sorry because I'm reading those questions as I can see them, so I'm sorry if they are not always very clear, but we will get to the bottom of it together. If a patient with isolated, oh, sorry, we can hear somebody. and the background. If a patient with isolated systolic hypertension who was using a triple treatment, do we just... I'm sorry, but we can hear somebody in the background, I think. Can we mute?
There is
okay.
There's a back on my side. Yeah, go ahead, please.
Oh, sorry. Yeah. If the patient with isolated systolic hypertension who was using a triple treatment, do we just change the treatment to monotherapy to amlodipine and just adjust the dose? No, well, we never take a step back, because changing triple SPC, triple combination to one drug, of course, is not a good idea. So maybe, I don't know, Professor Zudi, do you have any idea what this question might have been about?
Yeah, I didn't get the question well, but I guess the person wants to know whether what to do if a patient with triple therapy is not tolerating the medication. Is that right?
I think the question was just about isolated systolic hypertension. So maybe let's try to tackle that. What drugs would you recommend for isolated systolic hypertension?
Yeah, as we rightly said, we've been saying start with one single combination therapy. It's very important in all the patients, in the majority of our patients, to start with a single pill combination and then to rapidly escalate so as to achieve blood pressure control. And of course, in case of isolated systolic hypertension, amlodipine is one of that is regardless of the target organ damage and the cardiovascular risk. Amlodipine is one of the best medication in this situation.
We have another very interesting question. So hello everyone, my question is RAS inhibitors are used as the first line treatment for patients at higher cardiovascular risk. I wanted to know if there is a specific reason why beta blockers are not used. So we can say that beta blockers are not among the baseline drugs for baseline antihypertensive drugs, not among the first choice, first line antihypertensive drugs, because they didn't have convincing trials. So the reduction in cardiovascular events in patients with hypertension was proven for RAS blockers, for diuretics, and for CCBs. So this is why those are the first drugs of choice, and beta blockers are added always when we have specific indications. Professor Anastas, would you add anything?
Yeah, I absolutely agree with what you just said. I would just add that, of course, it doesn't mean that we shouldn't encourage the use of beta blockers, but we should look at our patient profile and knowing that based on the patient profile, beta blockers can be used at any stage of the treatment. But it's important to also look at the patient profile and to ensure that we use the right beta blockers, especially when there is target organ damage. If there is heart failure, then we will have to select those with proven efficacy in case of heart failure.
Another question to you, Professor Anastas: how to manage resistant hypertension?
The first thing, that's a very good question. The first thing I would like to say about it is that resistant hypertension, contrary to what we've been thinking, is not that fairly so frequent. So the first step is really going to be to ensure that our patient is really adhering to the medication and that there are no counter-effect interaction, maybe due to other medications that our patient is taking. And I will always advise before saying this is a resistant hypertension to ensure that you have out of office blood pressure. It would be good to go to ambulatory blood pressure monitoring. Now, if you confirm that there is resistant hypertension, also check for causes of secondary hypertension. And if finally you don't have any of that, then of course these are patients in which we are going to move to quadrilateral therapy. And the quartet trial shows that by adding a fourth medication, then we increase the chances of really controlling blood pressure and improving cardiovascular outcomes in these patients. But the key message again is to say, please, before you say that this is a resistant hypertension, ensure your patient is taking the medication, because I hear it is a huge problem in hypertension treatment and control. Thank you.
Thank you so much. Maybe one last question or two, although we have so many nice questions here. Something that we should definitely address is, what role does diet and lifestyle adjustment play in reducing blood pressure? Should the intervention necessarily be medication adjustment? So, of course, lifestyle is the basis, we could say, the fundament of everything. And we all know that it's better to prevent than to treat, but we also know that it is not that easy. And what is very important in the current guidelines is that in patients who are now diagnosed with hypertension, we should. I'm sorry, Professor Anastas, maybe you could turn down your voice, because otherwise we can hear, I think I can hear my voice doubling. The recent ESC guidelines have give us very straight recommendations. Once we have diagnosed hypertension, we have to give medication straight away. And of course, this goes in parallel with lifestyle modifications. So before, we had in the previous guidelines, you probably all remember that we said that if it's grade 1 hypertension, then we can start maybe for the first 3 months, we can start with lifestyle modification. If it doesn't work, then we will give drugs. But now, as you even saw at the very beginning, the title of the first presentation was "The First Weeks Decide the Next 10 Years," because we know that lifestyle modification is extremely difficult for our patients, and postponing introduction of antihypertensive treatment is bad for our patients, and it will lead to actually usually this postponement will be longer than just 3 months. So usually these patients will wait very long until with high blood pressure, with hypertension. So now, whenever we have hypertension, we give drugs directly, right away. Of course, we also try to address lifestyle modification. And now the only group where we start with lifestyle modification are patients with elevated blood pressure. So not hypertension, but blood pressure over 100, higher than 120/70. These are patients in whom we say you need to change your lifestyle. And actually, of course, a healthy lifestyle is something that we recommend to everybody. Now, in terms of hypertension, what we advise in particular is, of course, in its diet. The recent guidelines have shown us also that increasing potassium in your diet is also good for your blood pressure, but also naturally weight reduction and exercise. This is also something that will help to maintain healthy blood pressure values. But again, this is something that is not a solo treatment for patients who are already diagnosed with hypertension. Okay, so maybe, yes.
It's just to say that's something that question is quite of a frequent question. And the idea behind is that we still want to try what I call the stepwise hesitation. So we must really go for drugs, and we must go for this low dose combination, which is effective and which is very well tolerated. And we must really cancel this stepwise hesitation, which will definitely result in poor blood pressure control and increased cardiovascular outcomes. So I absolutely agree with what you just said, and I want to insist this because blood pressure control overall globally is very poor, and particularly in Africa. Thank you.
Thank you so much. We have another question, so maybe a last few questions. What are examples of monotherapy exception? So we've already covered patients with elevated blood pressure, not yet hypertension, but elevated blood pressure who are at high cardiovascular risk and who have their blood pressure above 130/80, despite those few months of lifestyle modification. In those patients, we would go for an ACE inhibitor, so basically a RAS blocker in monotherapy. But again, let's say not hypertension yet, just elevated blood pressure, so between 130/80 and below 140/90. And another group, as we already also said, would be patients, elderly patients. So for example, patients over 80 years old, and we all know that in elderly patients, indapamide would be a drug of choice for monotherapy. Maybe some last questions. The use of flozins, of SGLT2 inhibitors, is it to reduce blood pressure or control cardiovascular risk? Of course, to control cardiovascular risk. We know that SGLT2 inhibitors, they do have some small hypotensive effect, but this is not something that we use for blood pressure control. This is something that is that we can see, observe, but not on a large clinical scale. So we use SGLT2 inhibitors to improve cardiovascular risk. And of course, in patients with heart failure, they also have some small diuretic effect. And of course, we know that SGLT2 inhibitors are, let's say, statins of the 21st century. So basically that due to their pleiotropic effects, they are just wonder drugs. But reduction of blood pressure is, I wouldn't say one of those wonders. We also have a question, what are blood pressure targets in heart failure? Well, in heart failure, if we have patients with heart failure with reduced ejection fraction, blood pressure target, it's not, blood pressure is not a target per se. For us, the blood pressure, it is, our target is to increase the dose of GDMT to the highest possible doses, and usually this leads to very low blood pressure in those patients. So many of them will have a blood pressure of, for example, 100/60 or 90/50. Unless they are symptomatic in terms of hypotension, we are not afraid of that, and we even tend to, escalate the doses, because we also know that once the doses are escalated and that once the left ventricular function improves, blood pressure will stabilize and can actually go higher. But for the rest of heart failure patients who are not hypotensive, blood pressure targets are just as for any other patient. So in heart failure with reduced ejection fraction, our main goal is to increase GDMT doses. Okay, thank you so much. There are so many questions that we would like to answer, but I think it's now time for conclusions. So Professor Dzudzi, if you could please conclude.
Yeah, thank you very much, Professor Agnieszka. I think this has been a very interesting webinar, and from my point of view, there are key points in terms of take-home messages. So point number one is really to say there should be no more delay. So let's stop with stepwise hesitation. If we diagnose a patient with hypertension, then we have to initiate treatment immediately with SPC and we have to intensify rapidly to really achieve the blood pressure targets because based on what we start with, then this is actually going to determine the outcome of our patient in the next 10 years. Point number 2 is to say SPC is the gold standard, and we shouldn't be afraid. All the guidelines, all the evidence now convert to really tell us that we must use SPC as from the early phase, and that monotherapy should rather be an exception. Point number 3 is to say we must match our SPC to the dominant phenotype. And as we rightly said, if the patient has metabolic risk, diabetes, or CKD tendency, then a combination of perindopril and indapamide is going to be our best choice. Whereas if the patient has high cardiovascular risk or BP variability or stroke risk, then we better choose CCB plus RAS blockers. And point number 4 is to say if we are dealing with a Black African, then CCB must be the backbone of our treatment because these are patients with low renin activity, salt sensitivity phenotype, and we have enough evidence both from trials and also from guidelines, regional and international guidelines, that CCB combination must be preferred. Number 5 is to say if our patient is not controlled after 1 month of using SPC, dual SPC, then we must rapidly escalate to a triple therapy. This is better than increasing the dosage, and we have evidence for this. We've seen that this is going to improve adherence, reduce cardiovascular outcome, and even in terms of cost, and this is important for Africa, it is good to escalate to a triple therapy. And this is probably one of the reasons why the WHO has actually adopted this medicine in the essential medicine list. And number 6 is to say we must try to reach the target, and we look at the ESC 2024. This is systolic blood pressure between 120 and 129, and a diastolic between 70 and 79. We must also look at our patient holistically and treat all associated cardiovascular risk factors, because this is the way to really reduce cardiovascular risk and reduce the chances of complications. So in short, let's now forget about this stepwise hesitating and understand that SPC are really what we must be prescribed. Focus on the dominant phenotype, and if we don't achieve the blood pressure target, we should escalate rapidly to triple therapy. Let's act now, because every millimeter of mercury of BP reduction will actually save life of our patients. Thank you very much.
Thank you so much, Professor Anastas, and thank you to all our participants for the discussion, for the questions. We are sorry for some technical problems, but we hope that still this webinar was to your satisfaction, and I think we all learned quite a lot today. So thank you, everybody, and have a nice evening. Goodbye.
Thank you, Jessica. Thank you, everyone. Bye-bye.
Recording stopped.